Good evening. Welcome to our fall educational event. We are thrilled that you could join us this evening for a very insightful webinar that you'll be hearing in the next hour. I would like to, especially to give a warm welcome to our newest members as well as our guest this evening. My name is Elaine Shanley. I'm the current president of Anne Arundel Women Giving Together. So programs like these cost money for us. So we are thrilled to have such gracious sponsors to help us with the offset these costs. And I'd like to recognize them right now. Our leadership sponsors, One North Wealth, Sims and Campbell Trust and Estates, Anne Arundel Dermatology, and our advocate sponsors, Sarah Morris with Sotheby's, Ellen Shirey with Merrill Lynch, and Lara Saladon and Mark Baggins with Chesapeake Medical Imaging. So as part of our 15th year, we will be having our member meeting in a couple of weeks. We hope that all of our members can attend. And if you're not a member, you can quickly join and wink, wink, and we'll hopefully we can see you too at that meeting in November. There's a lot of updates that we've been working on this year, and it'll be great to see you at the event in November. So in a part of our 15th year celebration, we've had some really nice well wishes from the community. And so tonight we're going to showcase some of those from our current leadership. So we're going to play those videos.
Hi there, this is Sarah Elfreth. I have the privilege of representing the Annapolis and South County communities in the Maryland Senate. I just wanted to say a big virtual congratulations to the 15th anniversary of Anne Arundel Women Giving Together. Your impact is incredible. You know the numbers, $1.2 million to local nonprofits. It's the members of this group. It is the tenacity, it is the energy, it is the focus that has made a huge difference in our community. And I just wanted to say congratulations and thank you.
Hello, I'm Anne Arundel County Executive Stuart Pittman, and I just want to express my gratitude and my congratulations to Anne Arundel Women Giving Together for creating yourselves back in 2006, 15 years ago, and for inspiring one another, inspiring other women, and contributing to great causes all across this county and educating each other and educating me and educating the community about things that really matter. I think the last event that you did that I went to was on transportation. Things slowed down as a result of COVID with in-person meetings, but I'm really looking forward to getting together with you again and helping to educate each other and inspire each other to contribute to great causes and making Anne Arundel County the best place for all. Thanks.
Hi, I'm Mayor Buckley. Congratulations to Anne Arundel Women Giving Together. Congratulations on your 15th anniversary, and thank you so much for what you give to this community. Philanthropy and the Giving Circle have been a game changer for so many organizations, and it is all through your love and hard work that these people can make a difference. So thank you again from our city. We truly appreciate everything you do.
So nice to hear from our, getting those nice words of encouragement and praise from our current leadership. So now I'd like to turn it over to our educational chair, Barbara Hofstein, to introduce our program this evening. Thank you.
Thank you. My name is Barbara Hofstein, and this is my last program as chair of the Education and Programming Committee. It has been an exciting year of learning for me, and I am thrilled to end with this meeting that will hopefully begin a dialogue to put a spotlight on this shocking problem and lead to meaningful solutions. We are sorry that we could not do this in person because of COVID concerns, but Zoom will allow us to record this session. I hope you all had an opportunity to fill out our pre-survey. We have so many community stakeholders who are extraordinary experts here tonight, who thankfully were as excited about presenting this program as AAWGT was. Their names and short bios are up on the resource page under events of our website, givingtogether.org. We only have an hour and a half, and I hope my guests will agree with me. We want to get right to the subject. Who will save our mothers? Dr. Monica Jones, Systems Chair of Luminous Health, Women's and Children's Services, is our keynote speaker and will explain the current problems with maternal and infant mortality in this country and our county. She will broaden the conversation with our stakeholders working on these problems in our county and state. The conversation will be moderated by the 30A state delegate and my delegate, Shanika Henson, who addresses these kinds of problems in our state legislature, excuse me. Delegate Henson will first conduct a conversation asking questions to the community stakeholders and Dr. Jones, and will allow them to ask questions to each other. The chat is not available to you, but you will be able to ask questions in the Q&A feature at the bottom of your screen, which we will also address as time allows. Let me turn the screen over to Dr. Monica Jones. Welcome, Dr. Jones.
Thank you so much, Barbara. It truly is an honor and a pleasure to be with you all this evening. I am really happy that you invited me back after talking with you in March on the topic of leadership, but very, very pleased to talk to you tonight on the topic of who will save our mothers. Barbara and Tatiana asked me to put this together and to not use slides. And that was virtually impossible for me to do. But I did bring them along on the slide trail. And in fact, Tatiana updated my slide and told me that one of them was out of date. So I'm feeling pretty good about actually being able to put the slides together. So I'll jump right into it. We started with the conversation actually about infant mortality rates. And Barbara and Tatiana said to me, you know, the problem of infant mortality seems to be a growing problem. And it's really concerning that the United States is at the top of the list when we look at infant mortality rates. And so as you can see in this particular slide, some of them are excerpts from some of our national data, but it shows that in 2005, the United States infant mortality rate was 2.9 per 1,000 births. And in 2010, the slide that Tatiana helped me with, shows that we are at 6.1 per 1,000 births. And as you can see, relative to other industrialized nations, we really are at the highest level. So they began, Tatiana and Barbara asked me the question, what are your thoughts about this? And how can we understand some of the drivers? So in the bottom slide, the bottom part of this slide does show the common drivers associated with this, with infant mortality. And this was recently published in the JAMA Pediatrics Journal by Lenar and colleagues. And as you can see, if you look at the panels, the majority of the drivers are maternal factors. We have maternal demographic factors. We have maternal health and behaviors. So to have the conversation about infant mortality, you really can't have it without addressing maternal mortality and morbidity. And furthermore, having the collective conversation about what we could do to drive down these numbers for our mothers. The saying, healthy mother, healthy baby is true. It's a reality for us. So what I first wanted to do is do just a little bit in the way of level setting about some of the language that you'll come across as we start to have the conversation about maternal mortality and morbidity. And so what this busy slide shows is how we define maternal mortality rates or ratios, and also how we define pregnancy-related mortality ratios. This conversation will focus mainly on maternal mortality rates and ratios, and that is a maternal death of a woman while pregnant or within 42 days of termination of a pregnancy, regardless of the duration and site of pregnancy. And I just want to call out that a late maternal death takes into account a year after termination of the pregnancy. So those are the definitions that we tend to use when we're talking about maternal mortality. Well, as you could see in my arrow that's sort of going upward, we started to measure that with national vital statistics in 1933. But as you can see, it took a number of years for us to really attribute maternal deaths accurately, because for the first time in the history of collecting these data, it was in 2003 that we actually had pregnancy as a checkbox on a death certificate. So it took that long for us to actually get that checkbox on a death certificate. And then we started to capture the information a little bit more accurately. And some would argue that we almost overdid it, okay? So we did, though, pretty reasonably see that year after year, the number of maternal deaths over 100,000 births has slowly increased. We've refined these data, and we've invested a lot of money nationally and locally to refine these data. And we've done that by including and using actual literal death literals or actual causes of death to really try to understand why we are seeing this rise in maternal mortality. Disappointingly, though, as you can see, we are twice as high, and in some instances 3 times as high in terms of mortality rate compared, as you can see, to Canada and the United Kingdom. And unfortunately, as we've learned more about the causes of maternal mortality, it's become readily evident that maternal mortality for non-Hispanic Black women is 3 times that of non-Hispanic white women. Unfortunately, the state of Maryland is no different. If we look at the data collected by the Maryland Maternal Mortality Review, and it's presented in this publicly available report in 2019, in the state of Maryland, year after year, you can see a consistent disparity in maternal mortality by race, with non-Hispanic Black patients having over 3 times the rate of death compared to our non-Hispanic white counterparts, and then twice that of all races. When we look at the time that these maternal deaths are happening, we find that they most commonly happen within 42 days of delivery, or between 42 days of delivery and a year out. Well, we know why that time is important, right? We know certainly that public coverage of healthcare has a finite window where that can basically be impactful. So that's why we have to take a very serious look at how we are supporting mothers and how we're decreasing maternal mortality. I'm going to advance this. Well, what about opportunities to truly influence mortality? Well, and particularly address the drivers of maternal deaths. Well, we also look and capture in the public health realm maternal morbidity, and that is defined as any health condition attributed to and or aggravated by pregnancy that can have a negative impact on a woman's well-being or her quality of life. And in healthcare, we look at these as the near misses. We look at these as our opportunities to truly impact maternal mortality. And we consider them near misses because if we look at the literature, McDormand and her colleagues, she's at the University of Maryland at the time, and she published these data in the American Journal of Public Health. She has been able to show or describe at least a 50% of maternal morbidity can be prevented, and therefore maternal mortality can be prevented as well. So we classify this maternal morbidity as, and call it as severe maternal morbidity, and the CDC has a number of indicators. You look on the right slide, that's pretty much all of the 20 indicators that the CDC looks at and collects on a regular basis to characterize maternal morbidity. And what McDormand and colleagues have shown is that there are five leading causes of maternal death that are also classified in the CDC category of severe maternal morbidity. And these include postpartum cardiomyopathy, or an enlarged heart that doesn't squeeze like it should or effectively. It includes thrombotic emboli, or clots that form either in the legs and the lungs. It includes seizures and high blood pressure associated with pregnancy, also called eclampsia or preeclampsia, and then hemorrhaging after delivery, significant driver. And then finally, diseases of the circulatory system. So these are all conditions that in a significant percentage of cases can be prevented. Well, what about the rates of these severe maternal morbidities within the state of Maryland? If you look at the graph below, what you can see is that our numbers are pretty high. And this is actually measured in severe maternal morbidity rate per 10,000 deliveries. And as you can see, they're reasonably high. And you can also appreciate that there is a racial disparity in these severe maternal morbidity events or near misses. So it's not surprising that we have the problem of racial disparities in maternal mortality. And if we break our Maryland data down, as is done, the Maryland Department of Health provided these data to delivering sites such as ours, but they show that in Anne Arundel County, we do reasonably well in the state, but still have rates of severe maternal morbidity between 140, 188 per 10,000 deliveries. So the fact that many of the maternal deaths happen after delivery of the newborn, the fact that there's a three-time difference in maternal mortality between non-Hispanic Black patients and non-Hispanic white patients, and the fact that there are opportunities to prevent these conditions has caused us to ask the question, well, why is mortality continuing to rise? And my response to Barbara and Tatiana was, health systems have been trying for many, many years to do this work alone. And we simply can't. We need two things. We need partners. We need partners in industry. We need partners in government. We need partners in our insurers. And then we also need, most importantly, which Anne Arundel Women Giving Together represents, is we need community partners to really drive what is a significant influencer of health outcomes, and that is social determinants of health. So to take a minute to talk a little bit about what those are, is they really represent the environment in which people are born, live, work, and age that influence their health. And we know that that is influenced by social and political structures and processes that stratify individuals within society. And those stratifiers become income, education, occupation, race, ethnicity, and gender. And then there are exposures and vulnerabilities that all come into play in defining one's health. And that is no different for maternal health. So as you can see in this particular graph, the health system in and of itself really represents a small influencer of the entire maternal experience. Everything going on outside of that, or these social determinants, have, I would argue, probably a greater influence and really where we should be putting our energies. So at Luminous Health in Women's and Children's Services, what are we doing and how are we trying to bring our tentacles out in the community to address these social determinants of health? And I love this, Hal and colleagues, although they published this model a few years ago, it's very, very evident that we can't just look at maternal health in the moment and in the clinic experience. We have to go back even before mom gets pregnant and program in the space of preconception health once she finds out that she's pregnant, and then obviously after she's pregnant. And I'll give you a couple examples of why that's important. So if you have a mom that has preeclampsia or high blood pressure in pregnancy, she has a 12-fold risk of ending up with cardiovascular disease later in life. Moms that are diagnosed with diabetes during pregnancy have a 60% risk of developing diabetes, type 2 diabetes, as an adult. So we have the opportunity even before a mom gets pregnant to influence her outcomes as an adult, and therefore her health outcomes that lifelong through her whole care continuum. So what are we doing, and how are we getting into the community and addressing the preconception health, the antenatal care, the postpartum care, and beyond? Well, we do know that one form of prenatal care called centering pregnancy or group prenatal care, we know that decreases preterm deliveries. It's been shown in the literature to do that, and that is a significant driver of infant mortality. So in our practices, we've already had a practice, unfortunately, that had to slow down their centering program because of COVID, but we are still not deterred by COVID, and we're continuing to start centering back up right here in Anne Arundel County. We last year, thanks to a partnership with our Care First colleagues, did have the opportunity to have a doula program for a subset of our patient population, and we were able to show that mothers that had doula-supported births were less likely to end up with the cesarean section. And we know that if it's a first-time mom, a cesarean delivery is an opportunity. If we can prevent a cesarean delivery, if at all possible clinically, we know that sets her up for success with future deliveries and therefore decreases her morbidity and mortality. We're right now putting together our preconception health toolkit that we would like to implement through our cooperative care network within Luminous Health to address the issues of obesity, hypertension, and smoking even before moms get pregnant. We actually have 7,500 women, unfortunately, in our network that have these conditions of reproductive age that we want to influence and therefore improve their morbidity and mortality. And then finally, we're putting into place postpartum programs where we have social workers, care management, and individuals in place to help remind moms of follow-up appointments so that they don't miss their follow-up appointments, but then also navigate them to their primary care provider at their last prenatal visit, particularly if they're high risk, to follow up on issues such as hypertension and diabetes. We are also proud to have midwives as a part of our practices. We have a strong midwife practice and are able to offer moms that care if that's something that they want, and actually encourage it. And we're doing the work of educating our providers and our system around issues related to implicit bias and cultural competence, And I'm proud to say we will be ready when the state mandates that all licensed providers have to have this education, that our education will be done because we've started it already. And we're also very cognizant of not just culturally competent care, but cultural humility care. We are teaching our providers and our system to be culturally humble in the face of diverse patients, because we know it's through that amount of humility, or that action of humility, that's going to engage them in their healthcare process. Finally, just system things that we're doing. We obviously have safety bundles to address high blood pressure and hemorrhage and these high-risk conditions that we're faced with when women come to our doorstep. But it's our goal to prevent that from happening with some of these other programs. So I'm going to stop sharing the slide deck, and I am going to now turn it back over to Delegate Henson, and hopefully invite a lively discussion about what I've talked about, and really hopefully provide some solutions to the issue of maternal morbidity and mortality. So thank you all.
Dr. Jones, what an outstanding presentation, full of information that will help empower everybody that's on this presentation to be able to share information with someone they know and they love, to be able to take their health care, their prenatal care, and to do the most with it, and to look out for those pitfalls and to be an advocate for themselves and those that they love. So if you have ever been to an Anne Arundel Women Giving Together event, then you know that it's always full of great information. And at this time, we are going to take that information and we are going to amplify it, multiply it with a panel discussion full of powerhouse speakers that are experts in their field, that have made tremendous strides in women's health care, prenatal care. So as each of our speakers turns their camera on, we're all going to be in panel format, because if we were all together, this would be quite like a roundtable, a fireside chat, a discussion amongst friends, talking about women's health care and prenatal care. You've heard their bios and you have the links to them on the website. So as I introduce everyone, if you'll just give a wave so that people know who you are, they haven't yet had an opportunity to be familiar with your great work. I'm going to start by introducing, oh, they're still rolling in. Cameras are coming on. My panelists are rolling in. I think we have almost everyone. I think there we are, almost here. And the panelist I know the most, I don't see her yet. I know that she's here. I see her at the top. She's almost here. And there she is. I think we're all here. All right, I'm going to start with Dr. Glenda Lindsay. Please wave so that everyone knows who Dr. Glenda Lindsay is. Thank you, Dr. Lindsay. And I think that you're being pinned. Kristen Marshall, Anne Arundel Department of Health. Kristen. Gail Coffey, Anne Arundel Department of Health. Joy Hatchett, Maryland Insurance Commission. Hello, Joy. Dr. Michael Udwin from Care First. Dr. Udwin, thank you. Dr. Monica Jones, Luminous Health, our distinguished keynote speaker. Thank you, Dr. Jones. And my colleague in the Maryland General Assembly, our senator for this district, Senator Sarah Elfreth. Hello, everybody. So I want to pick up the panel discussion right where the keynote discussion left off. And I want to pitch the first question to Dr. Jones. Dr. Jones, you had a lot of great information in your presentation, and we know that your background is an OBGYN. But one of the things I want to understand is what other healthcare professionals play an important part in women's healthcare and in their prenatal and postnatal journey.
Thank you for that question. Wow, you know what we have learned through the pandemic, we can't ignore it, but we've learned that this work is multidisciplinary work. We know that it takes nutritionists, it takes behavioral health specialists, mental health specialists, it takes social workers, care managers. What we want to do though now is try to look and try to imagine, what can the community bring to us? What can churches, what can relationships with navigators in our communities, peer navigators, how can they get a seat at the table to help us improve the health of patients? So what we really want to do is get to the community and understand those resources and bring them in.
Thank you, Dr. Jones. Now that Dr. Jones has appropriately broadened the discussion for us, what you heard there was social workers, peer navigators, community members, churches, that this is everyone's responsibility, that we all have an important part that we can play in making sure that women's health care is provided for, making sure that people have access to prenatal and postnatal services and trusted voices and faces that will help them along that journey. So we want you to feel free to type your questions into the chat, understanding that this is a broad topic. It's not just doctors like Dr. Jones that have a wealth of information, but everyone has a part that they can play in making sure that babies are born healthy and that women are safe in the process. So the second question that I want to pitch is to Dr. Glenda Lindsay. Dr. Lindsay, you heard in there that dietitians are an important part of this health journey. Can you help us understand the importance of nutrition during pregnancy?
Yes, good evening. Thank you for your question. Nutrition is important throughout the whole life cycle, but importantly during pregnancy, because the mother needs at least 300 extra calories. She needs a well-balanced diet with fruits, vegetables, protein, grains, as well as fluid, plenty of water, vitamins, minerals, folic acid. So it is so important during pregnancy. I used to work for the Head Start program, and all the ladies that were part of Head Start, I had to see them as a dietitian. And so it was so important. They knew that it was important. And sometimes some of the ladies in the Head Start program did not see the importance, but I used to do home visits, tell them why it was important, give them diets, make sure that I sit and talk with them, and to help them to understand the need keep themselves happy, as well as healthy, as well as their babies. So it is very important. And if you want good outcomes, nutrition plays a very important role in good pregnancy outcomes.
Thank you, Dr. Lindsay. And I certainly think you could make a case for being happy as a great start to being healthy too.
Right.
Our first question has come in, and I think it ties in really well with our panelist, Kristen Marshall. Kristen, I want to learn more about the role of a parent educator. And the question that we have ties in with learning more about that. It says, when should education start for women? And I think that's great, because as a woman, there's a lot of different milestones in our life, thinking about having a baby, maybe not thinking about having a baby just yet. At what point should this education start? I think that's a really great question and a really great open door to explaining the role of a parent educator as well.
Thank you for tossing me that question. So I am a parent educator. A parent educator is a professional. I happen to have a background as a developmental specialist, and I partner myself with a parent. And what I do is I help them obtain the education that they need and the skill set to raise a psychologically, emotionally, and physically healthy child. Now, when do we start that? We start it prenatally. We start it before they even come.
Thank you. What a great response, and what a great support to provide. We have a wealth of professionals that's here. As Dr. Jones laid out for us at the beginning, the journey towards a healthy baby has a lot of professionals that are a part of that journey. So I want to turn it over to Gail Coffey. Gail, can you tell us about the Healthy Start program and what's happening at Anne Arundel County?
Yes, good evening. Yes, the Healthy Start program is a home visiting program, and it's composed of team members such as nurses, social worker, licensed therapist, parent educators, and a Spanish interpreter. And what we do is we do home visits to high-risk populations that is open to receiving our services, to let them know that we are there for them, so that they can have a healthy pregnancy and healthy baby. We help to connect them to all the services and the resources in Anne Arundel County, and help to make sure that they are aware of the services, such as the WIC programs that they may be eligible for, to make sure that they have their insurance in place, that they have their doctors, and that they realize the importance of their doctors in maternity care. Pediatricians, we help to make sure that they have that in place. So we function as a wraparound service for our population, and it can consist of teenagers, moms that are dealing with issues of substance abuse, alcohol, homelessness, just various factors, hypertension, diabetes, just a whole slew of factors. We are there to help them navigate with and through during their pregnancy.
That sounds like
it's absolutely
free
free.
services.
Mhm.
Wow, free services. It sounds like true wraparound services that are really there to support someone throughout their pregnancy journey to stay healthy. Want everybody that's listening in to know that the Anne Arundel Women Giving Together has provided a resource page on their website. So if you or someone that you know could benefit from getting more information about the wonderful program that Gail has just described, you can head there and get all the information that you'll need to connect with that program and other programs offered by the county. The next person I want to ask is someone that knows a lot about coordinating programs, starting programs, and getting resources that are needed into the hands of people that can do wonderful things like was just described by Gail. Senator Elfreth, you sponsored a major piece of legislation that has really helped to open the doors to prenatal health care here in Maryland. Can you tell us about what the landscape was like for healthcare access before the bill and what changes the bill has brought to prenatal health care in Maryland?
Sure. Well, thank you so much, first of all, Delegate Henson, for being our wonderful moderator. Our other teammate, Delegate Dana Jones, is watching. So all three of us are here tonight to support Anne Arundel Women Giving Together in this incredibly important topic of conversation. So I just want to say how grateful I am to come here and talk about it. The General Assembly has been trying to get our arms around this major policy crisis for years now, and we've made some progress at the state level. We received a report just about a year ago that laid out about 9 different policy recommendations on what we can do as a state to actually move the needle and actually to all of the indicators that Dr. Jones just spoke of. How are we going to move this and save the lives of women and babies? And a couple of those recommendations, we worked to pass them into law this last session. I had the deep privilege of sponsoring a bill to expand prenatal health care access to more Maryland women. So we know the facts. We know that this is something that disproportionately impacts women of color and women who are underinsured or uninsured. And so we kind of cut right to the chase and said, we're going to put grant funding behind programs that are going to provide prenatal health care to women regardless of insurance status. And it's a relatively small grant, $3 million a year. But our goal here is to build on that good work and keep the progress and momentum going. It was mentioned before that 2 other important pieces of legislation that passed in the last session related to prenatal health care. One is the cultural competency that Dr. Jones spoke to. My colleague in the Senate, Senator Melanie Griffith, carried that bill to make sure that that our healthcare providers are trained in cultural competency moving forward, and we can hopefully catch some of these incidents in time to save lives. And the last is Senator Mary Washington championed a bill to expand Medicaid coverage postnatal, so for full 12 months after giving birth. So we have prenatal, we have postnatal, we have cultural competency in here. We're hoping that this is going to help Maryland women. When 7% of Maryland women are giving birth without having a single prenatal care visit, we have a crisis on our hands, and it's something that we can fix, and we're working to do that. It's about healthy moms, healthy pregnancies, healthy babies.
Wonderful. Thank you for your work on that, Senator Elfreth. We know that while $3 million may be something that's small in comparison to the total state budget, it certainly takes a great deal of effort to get a program funded with $3 million and to dedicate that to women and healthy pregnancies. So thank you for your work on that in the Maryland Senate. I want to ask Joy, our commissioner from the Maryland Insurance Administration, about what programs like that, when they go into implementation and people are accessing health insurance through the state, Joy, what can people do? What can consumers do to get assistance with accessing health insurance? We know that sometimes we share some of the progress in terms of legislation, and people want to know, what does that mean for me? How can I tap into those programs?
Well, first of all, I just want to make sure that folks understand that my agency, we only regulate the private insurance market. So programs that are run by Medicaid and those type of programs are outside of our jurisdiction. What we try to do is if to the extent a person has private insurance, either through an employer or they've purchased it themselves, and they have issues obtaining coverage for services that they believe that their policies actually cover, then they can come to us and we can make sure that the insurance companies are providing them with the services they need under the terms of their particular contract. What we find frequently are that people won't seek out service because they don't think things are covered. So we spend a lot of time trying to explain to consumers what their policies actually cover and how to access those benefits, and also to make sure that the insurance companies have providers that are available, because that's one of the key things. Even if I have the coverage, if I can't get to the physician or the nurse practitioner or the nutritionist, it doesn't do a whole lot of good. So we make sure through all of our work on network adequacy to make sure that the carriers actually have providers that individuals can get to.
Thank you, Joy. That sounds like a lot of problem solving that's involved in your job and helping people really navigate complex systems. So thank you for the work that you're doing there at the Maryland Commission with health insurance. I appreciate it. Dr. Udwin, I would love to know more about Care First and what you all are doing there to reduce maternal child health disparities.
Yeah, thank you for the question, and Delegate Hansen, thank you for leading this and sponsoring this effort today around the panel. And Senator Alworth, thank you as well. Your words really resonated in terms of the legislation, in terms of trying to get early prenatal care and care as equitable as it can. And Joy, props again. This is exactly that. Everything you said resonated in what you're describing. We're strongly committed to it. And the fact that we're all here in a panel format just highlights that it's going to take everyone coming together to problem solve on this. It's a challenging problem that's been here for a while. And the fact that we're talking about today is really heartening. Care First is 100% committed to everything we're doing. Since 2009, we've devoted more than $20 million to this effort. And it's not all, to your point, about just insurance. We spent a lot of time in Be More for Healthy Babies in Baltimore City because we recognized they had one of the highest infant mortality rates in the country. And that we worked, again, collaboratively with organizations, with departments, with providers, with community organizations as well to address it. And it's made a difference in lowering infant mortality and in improving lactation rates and even making sure that members and folks who participate, who weren't always necessarily members, had contraception after their delivery. Again, to that whole idea of spectrum of care. The same holds true for Mamatoto Village, which I know when we were talking about doulas, boy, that resonated. The fact that that's going to make a difference. The idea of intervening early in prenatal care and taking them all the way through the journey, again, it makes a difference in lowering NICU rates and again, working at contraception and a healthy care afterwards. The final point I really want to make is around the fact that it's an integrated care model. We spoke earlier about the problems of mortality, not just at day 42, but afterward. And the fact that there's so much going on with Dr. Jones's work and other hospital systems at the postpartum period, that juncture of not just getting back up to their primary care, their OBGYN, but also to the primary care doctor, because like you noted, they have higher rates of diabetes, higher rates of all kinds of other complications down the line. And if we can get them plugged back in at the time of delivery back into the primary care doctor, we know that's going to make a difference. The final thing I just want to say is that the world has gone virtual, right? So we're here on a virtual call rather than just sitting around in a room, and we're trying to make care accessible, including information on lactation that's virtual, prenatal classes that can be virtual, behavioral health. The fact that now 95% of our providers can do so in a remote fashion, that's key. We have to meet members, not just around any other specialty, but particularly for this field, where they are. And it's not just maternity care, but the overall care for their community. So again, privileged and excited to be on this call and excited to roll up the sleeves and really move this process forward. Thank you.
Dr. Ubben, for the update on what's happening at Care First. It sounds like you all have some programs that can really be a model for how health insurance providers help to support the work that needs to happen across the spectrum. If we can revisit one of our providers with Dr. Jones, we have a question about Anne Arundel Medical Center specifically. If you can also touch on, because I think it bleeds back into the social determinants of health that you mentioned in your keynote. Someone's asked in our chat, what percentage of women that deliver at Anne Arundel Medical Center have no health insurance, and how does that affect their care?
Mm-hmm. Thank you. That's a great question. It's often an underrepresented number, but off the top of my head, I think in the last fiscal year, that number was about 10% of the patients that we see. So one of the other programs that the health system has gotten behind, in addition to a midwife program, is our hospitalist program. We have a team of dedicated physicians that see all of the patients that are unassigned and that see patients that don't have prenatal care when they come in for an acute event into the hospital. They then do the work in partnership with our social workers and care management team to see to it that they get keyed into a prenatal care practice. And we are pleased also in July to have started a residency program, and we have OBGYN residents that play a role in some of the prenatal care that we deliver to women that don't have a provider when they show up to our door. So we have two outstanding programs. One is a training program and one is a robust hospitalist program that helps us to take care of patients without insurance.
Thank you. It's wonderful to hear the work being done at Lumenis to make sure that quality care is being delivered and that programs are expanding and growing to meet the expanding and growing needs that exist here in Anne Arundel. When we talk about the needs that exist, I know that Dr. Lindsay, your comments about the need for nutrition during pregnancy spoke to that, but also you have a background dealing with mental health as well. Can you help us understand the importance of caring for mental health during pregnancy and after pregnancy as well?
Yes, I will definitely do that. I have a background in public health, but also I have spoken on mental health and how mental health affects pregnancy. Because a lot of times young ladies may have some mental issues before pregnancy. And then when after pregnancy, or during pregnancy, it might magnify because of some of the, as Dr. Jones mentioned, some of the social determinants of health. They see themselves and not having enough food, not having a proper place to live. And so, and with anyone, not just pregnant women, if some of those things are out of sync, then you have some mental illnesses. And then again, I think someone mentioned, or it might have been another conference I was on today, about drug abuse. And also if they do have some drug abuse problems, then the mental health issue will increase. But also you must remember too, that pregnancy is supposed to be a happy time. But if some of the social determinants of health are not in place, housing, food insecurity, even the geographical location, some parts of Maryland, or even if you look at Baltimore City, some parts of Baltimore City, the maternity rates are lower in terms of, mortality rates are higher in terms of where the person lived. As a member of the American Public Health Association, we did a conference several years ago on geographical location and health. And so that has a lot to do with your health outcomes, where you live, how much money you have. And some of us who have been okay down through the years, we say, well, that wouldn't affect us. But if you put yourself in that predicament, you know that it will affect you, not having enough money, not having enough food, and things of that nature. And it will cause you to not, I remember distinctly, and I'm gonna be quiet. I had in one of my behavior science class in my public health graduate work, one of the teachers, and she was from New York, and she said, you have to care about your health in order to do something about your health. And it was a Friday night class. I went home that evening just thinking of that. First, you have to care. And so many times, a lot of pregnant women live in conditions, live in environments where nobody really cares about health or so many other things. And so if you care, you're going to make the first step. If you don't care, you're not, it's going to be, well, I'll do the best I can. And you're not looking out for yourself or the outcomes of a good outcome for your baby.
Dr. Lindsay, I think that what you did was just tie a thread that good mental health during pregnancy and beyond, it's not always a diagnosis or something that feels overwhelming. It starts with the simplicity of caring and being invested in your health care. So I think that was an excellent point to make, and it can help everyone that's on the line if they're in a position of trying to look out for someone they care about or empower somebody to be an active participant in their health care, to know what to look out for and to start at that basic level of do they care about their health care? Am I caring about my health care? I think that's an excellent point to make. You got a follow-up question, Dr. Lindsay, and our someone from the attendees wants to know, what, if anything, do you think the connection is between good prenatal mental health care and the health care of, or the mental health of children? Do you think there's any connection there in making sure that women are supported with mental health care during pregnancy and mental health of children?
Well, it's a great connection between those two. I teach a parenting class at Morgan State University, and I always emphasize to the students, and we talk about pregnancy, we talk about nutrition and so forth, but we also talk about parenting and how it's important to have a healthy attitude when you're a parent, because it works on you. Well, it is a part of what your children see. And they see that you are sad and you can't make decisions. And then they see life as that's the way it's going to be. And we talk about also functional and dysfunctional families. And dysfunctional families, there's no communication, there's no happiness, there's no, let's go out to the park and play and look at a movie together and laugh. And so, but sometimes when you're in a mental health episode, you don't want to do things like that. And then it goes from one generation to the next, that they look at a lot of children. It's not so, it's more of the mother and father's mental health too. But a lot of children are very close to their mother, and they see their mother in despair, and they may think, well, that's the way life's supposed to be, but it's not supposed to be. And I always tell my students at Morgan, you have, as the Constitution says, and not that I'm a Constitution person, but you have the pursuit of happiness. You are not supposed to be a sad person, but a lot of times in communities of color, we think that's okay. And I have a discussion board with my students, and one of my questions I'm going to put this week is, how can you be happy when everybody around you is unhappy? How can you be sane when everybody around you is insane? And if you do that, that's a great thing, a great accomplishment you can do. because it's very difficult, because a lot of the students write me and they tell me about the dysfunctionality of their families, but they made it to college. But then there's some students that never will make it because of this dysfunction have been so great.
Dr. Lindsay, for that uplifting work. Appreciate learning more about that. I wanted to turn it to Kristen. Kristen, we have a question, and the question is asking about experiences that you've had as a parent educator with parents in particular. I think that we're looking to understand what some situations might look like where we can empower parents and families that could use a little bit more support or resources. Can you give us any examples that you've seen in your work of families that you've got a chance to work with?
Yes, I will share some stories with you, but I want you to know these women that I'm going to talk about, I got permission from them to share these stories. It's their stories, it's not mine, and I'm just being a conduit. So the first one I'll tell you about is a 31-year-old woman I'm working with currently. It's her first pregnancy. It's complicated by her having a seizure disorder. She used the Flow app, but she didn't realize she was pregnant, so she didn't seek care until about 8 weeks into the pregnancy. And she was treated as if she was not body aware because of this. She had her first sonogram, was told everything was fine. She did end up having a seizure. After the seizure, she had a second sonogram, and it was noted that she had a large fibroid. And she said, "What is that? What do you mean large?" Became very concerned, went back to the provider, asked the provider some questions, and she was dismissed as, "We didn't tell you about it because you don't need to worry about it." And then she was like, "Huh." And they were like, "Don't worry about it. You're fine. Everything's fine." She was never educated why she was fine and why she didn't need to worry about this. She had another issue where when she was younger, she had piercings and she's worried about that with breastfeeding. She tried to explain her concerns there and she was dismissed. She came back for another appointment recently and was just quiet because she just felt like she wasn't being heard. So she's just quiet. So the doctor said to her, "What's wrong?" And she said, "What do you mean what's wrong?" And he said, "Well, usually you're so talkative, so something must be wrong." And she said, "So you think because I'm not talking, something's wrong?" And he said, "Well, you don't need to get an attitude." And she said, "So now I have an attitude." And so now she says that after this next visit, she really wants to find another provider. And her situation is really difficult because there is a specialist that she can see that's up in Baltimore. She does have Medicaid. Medicaid is limited here in the county on how far they'll go with her unless she gets a written notice saying she needs to see that doctor. Well, we just hooked up with her very recently, so we haven't had time to get. Luckily, we were a recipient of some funding, so we were able to get her an Uber for her to make her appointment to that specialist. So that's just one of the stories. If you want, I can share more. Okay, so the second mother I have, this mother just came to us recently. She's 33 years old, first pregnancy. She hit 6 months and became very, very depressed. Spent the weekend crying and called her provider on Monday and was like, "I don't know what's wrong with me. I can't stop crying. Like I've been crying for days now." And she was told, "This is normal. You get emotional go take a walk, you'll be fine." So luckily she called our therapist in our office, and our therapist was able to contact her provider and she had a prescription within 2 hours. And I did see this young lady today and she's feeling much better. She's much calmer. She says her prescription is working. And I'm just so glad we were there for her. Then the third mother that I work with, this mother had a lot to tell me, so please bear with me. She She's a wonderful woman. She's 28 years old. She has 2 children now. She has lost 2 children also. She, so what I'm going to tell you right now, this goes back to what Dr. Jones was saying about that social determinants of health. She said something to me that my grandparents have never said to me. And I thought this was like one of those things where it really showed the difference in how me as a white woman views pregnancy and what she's going through. And it pierced my heart when I heard this. She said her grandmother told her, you know, every time an African-American woman gets pregnant, it means one foot's in the grave and one foot's out. And I thought, wow, to walk into your pregnancy with that. So I'll go on with her story. Her first pregnancy, in the 3rd trimester, she had high blood pressure, fluid retention, headache, upper stomach pain. I'm sure Dr. Jones is probably leaning towards, sounds like preeclampsia. But because she did not have protein in her urine, she was never told she had preeclampsia. It was never written in her chart. She then got pregnant a couple years later, and she said that it was about 8 weeks in, she had elevated high blood pressure. She was also treated as being bodily unaware because she didn't know until she was about 8 weeks that she was pregnant. She did lose that baby before the 2nd trimester. Her 3rd pregnancy, she was slightly elevated blood pressure at 12 weeks. Concerns were not taken seriously, even though she brought them up saying this happened to me before. And then she started getting complaints of pain in her abdomen. The sonogram showed everything was normal at 13 weeks. She was working in an OBGYN office. She said she had to look in the office for teaching moments to learn from, because no one was talking to her about preeclampsia and she was feeling unwell. She suffered a loss at 24 weeks. Her 4th pregnancy, everybody took her serious. She got into a high-risk program. She said under that care, she was checked out all the time. If she had an issue, they were checking it. One time she wasn't feeling well, they caught a UTI. She had gestational diabetes. They were on top of it. And she did give birth to a healthy baby boy in September. And so, but even today or yesterday, she reported to me that she is having high blood pressure issues after the pregnancy. And we did get her to go to the doctor. And so she's following up on that. All of these women have wanted me to share these things to you. She says, all the women say, please don't shame me for not knowing I was pregnant on the 1st month of the pregnancy. That just should not be body shamed for that. Please educate in the office visits about what is happening to me and the things to be aware of. Explain everything that is discovered. Don't hide anything from me, and tell me why I should or should not be worried. And treat me the same on baby 7 as baby 1. And they said, stop being dismissive and judgmental. Listen to me and what I'm telling to you. Don't group people in a population. Look at the individual, make an individual plan. Listen to me. Drop the stereotypes that Black women can endure more and are stronger. And if you put a person in a box, then you're going to keep them from getting the care they need.
Phenomenal and courageous women that were brave enough to share their stories so that we could all learn. Thank you for the work that you're doing with them. And most importantly, please thank them on behalf of everyone for their bravery and their courage and sharing their stories and continuing on their journeys for healthy pregnancies. That was, I think we've all taken all of that to heart. Thank you.
Thank you
Gail,
for giving them a voice.
Gail, I think the next question that came in is appropriate for you and appropriate for follow-up on what Kristen just mentioned, unless Dr. Jones wants to jump in and give us some information that we can share with women in that position, and then we can kick it to the next question.
Well, I honestly, I don't want to take a lot of time to do this, but I just personally want to apologize on behalf of her health experience or the health experience of some of those women. We all recognize that none of them were experiences that we would want anybody that we're related to or not related to have. And so I really do apologize as a healthcare provider that your patients had that experience. But I'll tell you and not really, but I'll tell you what's going on that's great that's going to prevent that from happening in the future. Number one, we have evidence based on large studies to show that if you give women aspirin in the early part of their second trimester or the latter part of their first trimester, you can prevent preeclampsia. So the conversation around hypertension, it starts in the first trimester. So to shame someone for presenting in the first trimester is somewhat concerning to me. But anyway, the first trimester is an opportunity to prevent a lot of things related to pregnancy, and that's why we encourage people to present in the first trimester. So please continue to do that in the population that you're taking care of, Kristen. Also, if you wouldn't mind, please send me, if you wouldn't mind, that all of their notes that they just said that they want from healthcare providers, because that will go in my chairman's chat, my next chairman's chat, to everyone in my department. Because everyone in my department needs to know that if there's one person that's experiencing it, there's a lot. And we need to know that's not acceptable and that's not what we want to foster in healthcare. So thank you for sending me, if you wouldn't mind, those comments.
Seeing Kristen give a head nod to say she absolutely will uplift their voices and share that with you, Dr. Jones, so that you can take action on the brilliant requests that they've put forward to say, this is how we can help tackle these issues. How better to start than hearing from people themselves that have journeyed that road. Gail, we have a question in the chat that's asking, are there community-based support groups that could help women like the ones that we've just heard from through Kristen? Are there groups that they can visit in the community where they can be surrounded by women in similar circumstances to receive uplifting support from community groups?
Yes, I'm sure there are community groups in the area. I am not aware of all of the particular ones, but I know that they exist. I know there are community groups through the hospital, through Anne Arundel Medical Center, and through the other different areas. I just don't have a list of all of the particular ones, but I know there are community groups that exist. And I don't know if Dr. Jones or any of the other panelists would have more specific information as well.
That's very kind to open up the floor. If anyone else wants to chime in on that before we get into the last round.
Yes, there are definitely community groups, support groups. One of the reasons why we endorse centering pregnancy, because it's like group prenatal care. So, but to your point specifically, if you guys have a list page that I could get those names and then post them on your page, I'd be glad to do that.
Wonderful. So we'll follow up on that and make sure that those support groups are part of the resource tab on Anne Arundel Women Giving Together on the website. So you can visit the website shortly after, and we'll make sure that it's updated with those support groups. So for the last round of questions, I want to ask each of the panelists the same question. And that question is looking to the future. What's next? So what do we have left to tackle? How do we get over the next leg of the journey? How do we get through the next milestone? So all of the women that are on the line, all of the supporters that are on the line that want to empower the advocates that do this work, that want to empower the women that need these services, this is where you take out your pen and pencil or your iPad and virtual notes. You can write down what these panelists are about to say, because this is the next thing that's going to need your support and need your advocacy to be accomplished. So I want to start with my colleague, our Senator for District 30, Senator Elfreth, what do you see as the next thing that we have ahead of us to tackle?
Well, thank you so much. And thank you to everybody for being here. This is a really exciting time to be in the Maryland General Assembly. You've probably heard me say this, but we have more women, more people of color, more people under 40 than ever in the history of Maryland. And we're tackling issues like prenatal and infant mortality and health like never before. So I mentioned the prenatal care funding that we put into place, and greedy self-interest. I want that money back in this district. It's statewide, but we want to bring that home to Anne Arundel County. But this is a statewide challenge. It's a statewide challenge on the Eastern Shore in Baltimore City, Western Maryland. So we're going to need to expand that coverage. We also put $15 million a year behind closing health disparity gaps in our communities. So that's a really exciting. We need to see the implementation of that equitably across our state. And then the last exciting piece, I mentioned that report, and I will drop it in the chat for everybody because it's a great read. I actually teach it to my public policy students. One of the recommendations was to expand Medicaid coverage to doulas. And I'm very excited. I just had a meeting the other day that Maryland will be seeking that waiver. So we are relying on the federal government to give us that waiver, but very exciting time to be in this work. And I just want to thank everybody for being a part of it. We will keep moving this ball forward with every breath we have. Thank you.
Thank you for your work, Senator Elfreth. I appreciate your work in the Maryland Senate and everything that you're doing to just uplift our community here in Annapolis and Anne Arundel County. I want to ask the same question to Dr. Lindsay. Dr. Lindsay, what's next? What can we do to move this work forward and to continue to support healthy pregnancies?
Thank you so much. I listed several things, the increase in minimum wages, and I got that from my colleague and friend, Barbara, and we were at a conference on hunger, food insecurity, and Barbara mentioned if we increase the minimum wages, we wouldn't see that as much. Education attainment from K through 12. And because racism starts even at those age, even in early child development, moving on to the 12th grade and beyond, that we can improve the outcome of women. Increase availability to affordable housing. And that's so important because housing is more of a profit than where should people stay. To Senator Sarah, thank you so much, because I did say legislation on local, state, and national level. That's very important. I am the public policy coordinator for the Maryland Academy of Nutrition and Dietetics, and I deal with that all the time. I didn't know I was going to get so engrossed in it, but I think about it every day. For example, the Build Back Better Act, hoping that will pass. Create more food insecure families and communities with SNAP benefits, as well as food pantries that have as Ms. Gail Coffey mentioned, a wraparound experience when they go to the food pantries, that they can find out more about housing and medical care and things of that nature. And most importantly, and not the least, equal rights for women. And even now in 2021, women still struggle. So we still need equal rights and wages as women. Thank you so much.
Thank you, Dr. Lindsay, for that outstanding advocacy that really covers the board on where we have left to expand our reach to make sure we are doing more to support women and families. So if Dr. Udwin has anything to add to that, I'm going to be really impressed, because that was an amazing list of resources for us to get started on. Dr. Udwin, what's next?
Yeah, that's hard to follow, I'll be honest. I want to pick up a couple things there. One, the theme around culture of humility, Dr. Jones's comment at the beginning that, and these stories that Kristen articulated came to the same thing, the idea of being way more sensitive and much more aware than we are now. So I think expanding that education, anything we can do to support that, all in favor of. Coming back to the idea of you manage what you measure is so key. And I think we're very focused now on understanding the social determinants of health and how to measure that and understand where we need to be focused. And I think that comes back to the measures themselves. Are we really understanding who has had prenatal care early in the pregnancy, who is having the appropriate follow-up after delivery, even vaccinations. Are they having vaccinations? Are we screening for behavioral health issues early in the pregnancy, and are we following up later in the pregnancy? And finally, the commitment of reducing the inequities in care that we see and the access to care that we see. That I think we're very focused on that. The final thing I want to talk about is just that we talked about it with the doulas, we talked about it with midwives, we talked about it with centering pregnancy. Just integrating and expanding and being creative. The one thing that COVID has taught us is that we need to think outside the box, to come back to that analogy of the box, that throwing out as many new and creative brainstorming ideas as we can and seeing what works. What works in one community is not going to work in all communities. And we need to be able to think big and think bold and be audacious as we move forward. So excited to be a part of this panel, excited to see this advance. Thank you.
Thank you. That's wonderful, wonderful charge for us and where to head next. Joy from the Maryland Health Insurance Commission, can you help us understand what's next on the front to support healthcare?
One of the major things that I would like to see is getting people enrolled in a healthcare plan early on. So when those kids are in high school, some of them are on a parent's plan, that's great, but a lot of them are not. So if we can encourage them to join a plan and to stay on that plan when they're out working on their own, be it the Medicaid, something through the Maryland Health Connection, something, because that healthy lifestyle will help them for the women when they do become pregnant. So you start them young, and then hopefully they will learn how to take care of themselves so that when they do become pregnant, they do have a healthy pregnancy.
Thank you. Same question goes to you, Kristen.
Oh, I'm really excited. This is the first time in years that I have this many prenatal clients on my caseload. So this is huge. And I'm excited for a Healthy Start because we did get some grant money and we're going to be hiring 2 more nurses, 1 more parent educator, 1 more therapist. So that's very exciting. That's what I see on the future. And I just would love providers to remember that we're out here. We can wrap our services around those vulnerable women that need it.
Great. And Gail, what do you see as next on the horizon for making sure we deliver quality services?
So the same thing, Kristen and I are co-workers in the same program. So the same thing, just hiring more staff. And as a matter of fact, I think like with the Healthy Start program, if it could be statewide, I always thought in the very beginning that every county had something like this. And I didn't realize until after we were working the program that that wasn't necessarily the case. So it would be nice. And I'm so glad to hear from the senator that the funding, the bills that she has pushed through, but it would just be wonderful to see the Healthy Start program statewide, more money, especially for transportation for our young ladies who don't have access to transportation. They don't have cars and things of that nature.
Wonderful additions. And ending this part where we started with Dr. Jones, what's next for us to accomplish here to make sure we're delivering quality care?
Well, thank you so much. Everybody's pretty much said everything. Just a couple of things that I wanted to call out specifically because I have such wonderful partners already on the call, Senator Elfreth, Dr. Udwin and his team. Chris, just really excited of the relationships that we have already. But definitely moving forward, we need funding mechanisms to really help these relationships in the community between health systems and community partners. We really do need funding mechanisms. We also need funding mechanisms to, as Dr. Udwin said, understand the numbers. We're a regional health system, but a lot of the funding for support of understanding the numbers goes to academic centers. Well, we are in Luminous Health, the second busiest delivery site in the state, okay? And the funding for the research goes to our academic partners more so than us. So we do need those resources to understand our outcomes. We really would like to see support for preconception health and care and programs that foster those partnerships between OBGYNs and primary care providers so that we can get our moms healthy before they get pregnant. And when we do that soft handoff, thank you, Dr. Elfreth, for getting that funding through the whole year. At 1 year, then there's a soft handoff and it's structured and paid for and supported. And then finally, we did see in the report, the governor's report in 2019, the real push for remote healthcare monitoring, remotely monitoring blood pressure, remotely monitoring oxygenation levels and pulses, and really engaging patients in the care process, giving them some ownership of care, and doing that in a remote way is going to really, I think, be a critical key to improving maternal morbidity and mortality. So I'm so grateful to have been on this panel and so grateful to have this time with such wonderful panelists. And thank you, Delegate Henson.
Thank you to all of our panelists. If everyone can give them a virtual round of applause wherever you are. You all have done an outstanding job to help empower all of us to be great advocates for ourselves, for our friends, our family, for all of the women and mothers that we know and love and hope to be. Thank you to Anne Arundel Women Giving Together for hosting this panel discussion and for bringing quality education topics like this to us so that we can all be great advocates. At this time, I'm going to turn it back over to our education chair, Barbara Hofstein.
Wow. This was wonderful. I'm so glad this conversation started, and I'm so glad that we had these panelists all with us, and I can't wait to see where it goes forward. So thank you all. And I want you to know that in addition to getting up, I like that idea that we're going to get up on our webpage a list of groups that will be supportive to each other. I want you to know that I hope you did your pre-survey, but there's also going, when we get, this is all recorded, so when we get the recording up, we will also send a post-survey. Which would be very important for us. So thank you all. Thank you to our audience and your wonderful questions, and good night.